Hi guys, welcome to week 9, hematology, immunology, and infective disorders. I'm Amy, you know that. All right, so please bear with me with this case study because as I go through it, you're gonna be like, you might be like, how is this hematology, immunology, or infective disorders? I'm gonna get to it. It's a long story, here we go. Or not. So subjective, chief complaint, I'm returning for the wounds on my legs. Side note, I did the first 6 weeks of clinical at the wound center at work. It was phenomenal and an awesome experience. But it really restricted the clientele I was seeing for this presentation. So this patient is a 74-year-old man who returns to the wound center for a 1-week follow-up to evaluate and treat his bilateral lower extremity ulcers. This is his 5th weekly appointment to the wound center. This patient initially started with one area of eschar with one eschar covered necrotic ulcer to his right lateral lower leg, which has now shown significant decline, and he has a second ulcer to his left lateral lower leg, which was first noticed at his 2nd weekly evaluation. Patient reported these wounds have also shown significant decline over the past week. This patient has no arterial insufficiency noted. He does have venous insufficiency. The patient was started on bilateral Pro-4 4-layer compression wraps 1 week ago at his last appointment. He has a past medical history of AFib, DVT in the right leg, diverticulitis, dyslipidemia, heart murmur, mitral regurgitation, obstructive sleep apnea, osteoarthritis, CVA, type 2 diabetes, neuropathy, CKD, stage 3, hypercholesteremia, and GERD. Here's a list of his current medications: Entresto, Tums, Coumadin, Farxiga, atorvastatin, metoprolol, folic acid, ferrous sulfate, torsemide, potassium chloride, and Protonix, which I'll coordinate with his diagnoses. He is allergic to bee stings and goes into anaphylaxis. He does carry an EpiPen with him. He's allergic to Norvasc, the reaction's unknown. Adhesives, he gets a rash from. Benzene, the reaction's unknown. Chlorhexidine gluconate, also unknown reaction. And sulfonamide antibiotics, he gets hives. He has quite the surgical history as well. As you can see, he's had 2 cardiac casts. He's had his gallbladder out. He's had some angioplasty with stenting to revascularize his right leg. He's had a mitral valve repair, bilateral knee surgeries, patent foramen ovale closure, tonsillectomy as a child, right total knee replacement. Oh, I should have taken that, my bad. Oh, he had it redone. He must have done one in 2013 and one the next year. Transesophageal echocardiogram. His social history: he's a retired engineer who lives in a single-family home with his wife, who is present at his appointment today. He quit smoking in 1980. He denies alcohol use, denies drug use. He has a family history of cancer, heart disease, hypertension, and kidney disease. So my review of symptoms. This patient reports pain around the wounds at 5 of 10 most times. During wound care, I'm sorry, you guys, I thought I took care of those, so I wouldn't be in the way of the writing. With wound care, his pain goes up to 8 out of 10. He reports the pain has increased since the wounds became larger. He denies fever, chills, or change in appetite. Respiratory, he denies cough, wheeze, or shortness of breath. Cardiac, denies chest pain, palpitations, edema of the extremities. Skin, he reports bilateral lower extremity ulcers with weird blotchy skin of the legs, itching to the lower legs when patient had multi-layer compression in place. He did have the wraps changed once over the past week. He reported he tolerated them fine up to the first change, and then they just got so incredibly itchy he had to take them off himself the day before the appointment. He denies an increase or change in drainage. That is wrong. He denies an increase or change in drainage, wound order, or any new lesion, wound, or rash. The wounds are getting bigger though. He denies depression or anxiety. Objective findings: blood pressure was good, pulse was good. Respiratory rate is fine, no fever. Oxygen set is 95% on room air. He is 5'9", weighs 250 pounds with a BMI of 36.9. He had, the wound center did ankle brachial indexes on 5'4", which was his first appointment. I'm not quite sure why they didn't on him, because ankle ABIs are in diabetics not valid. I don't know if that's the right way to say it, but they tend to have false elevation ABIs in diabetics because of the atherosclerosis that occurs in the legs. Diabetics should always have the venous or vascular studies. He did have arterial studies on May 10th, which show no arterial insufficiency. His previous angioplasty remains patent. He also had a dermatology consult on 5/12. The dermatologist did biopsy of the eschar covered wound. The biopsy showed cutaneous cells, fibrosis, astatic vessels, findings regarded as nonspecific, suggestive of vasculopathy with reparative fibrosis, such as livedo reticularis or vascular stasis as the cause of the wound. Livedo reticularis, I have a picture of that later in the presentation. It looks very much so like mottled blotchy skin. On 5/23, he had venous Doppler studies completed with vascular, minimal venous insufficiency reported to his legs by lat. He is scheduled for some small venous ablations with vascular over the next month. So physical exam. He's constitutional. He ambulates slowly with a rolling walker with a seat. He's well nourished, well developed, alert, awake, oriented type person, place, time, and situation. His respiratory is unlabored breathing, no accessory muscle use noted, no cough noted. Extremities, his feet are warm to touch by lat. His cap refill is less than 3 seconds to his toes. There is a mottled appearance of discoloration of the skins from the feet to the thighs. The left lateral lower leg wound measures 7 by 3.4 by 0.2 centimeters. His wound bed is mixed slough with adipose exposed and pink non-granular tissue mixed in with the adipose. Moderate serosanguinous drainage. Peri-wound is intact with mottled skin noted, no signs of infection noted. The right lower leg ulcer is quite a bit bigger. 7.8 by 8.5 by 0.2. The wound is wound bed is also a mix of slough with adipose and pink non-granular tissue noted, moderate serosanguinous drainage, mottled skin around the wound, no signs of infection. No other new wounds, rashes, or lesions noted. Psychiatric, he's calm with an appropriate demeanor. We did perform a procedure during this appointment. Lidocaine 2% gel was paced bilaterally to the legs for 10 minutes. Using a curette, we debrided slough and fibrinous tissue from the wound bed. The patient tolerated the procedure well and reported a pain of 2 of 10 during debridement, which decreased after debridement was ended. So assessment. Patient is a 74-year-old man with all sorts of unknown etiology to his lateral right and left lower legs. The diagnosis is full thickness bilateral ulcers of the right and left lower leg. The ICD-10 coding, there's actually one for each leg. So differential diagnosis, what I picked was vasculitis with livedo reticularis changes. And that picture in the bottom right-hand corner is that mottled look. That is exactly how his legs looked. And usually livedo reticularis is a result of vasculitis. This may be a vasculitis, which is usually autoimmune, but he needs further testing. No biopsy has shown that. Venous insufficiency is another differential diagnosis. He does have some venous insufficiency, although I just don't think that is the cause of these ulcers. I didn't think that was the cause of the ulcers because they never presented typically like venous ulcers do. They were never, usually venous ulcers are large, irregular, wet, very wet. And his original ulcers were dry and necrotic. Which is like unheard of with venous insufficiency ulcers. It could also be an autoimmune dermatological disorder. he's being referred to another dermatologist from the first dermatologist because he can't figure out what it is. So it could be possible. Maybe he needs to see rheumatology at some point, but he's not quite there yet. He also has a diagnosis of diabetes mellitus with neuropathy. The diabetes will certainly affect his healing ability, and he does have venous insufficiency, although not the cause of the ulcers likely, but it definitely is affecting his healing ability as well. Venous insufficiency ulcers generally only heal with compression. You got to get the fluid out of the leg before you can ask it to heal. So the plan for this patient, he was referred already from his local dermatologist, as I just said, to a specialist dermatologist at Yale. His appointment was the following day after this appointment. So we did not reapply multi-layer compression dressings at that time. Instead, we provided the patient, but we did provide the patient with information for this dermatologist to send a report to the wound center after consult. We asked him to please have him send us a report. If not, they will get it from the dermatologist that they referred the patient to. We did, oh, here it is on there. The patient was encouraged to keep his follow-up with vascular for planned upcoming venous ablations. Instructed that even if his wounds are not venous in origin, his venous insufficiency is likely contributing to the decline of his wounds, and the patient verbalized understanding. The new wound care orders today were for daily wound care, apply a nickel thick layer of Santal, which is an enzymatic debrider. The only one on the market. That stuff's expensive. Followed by ABD pads, followed by a gauze wrap with tape, and 1 layer of tubigrip size E for minimal compression. He can pull the tubigrip down pretty easily, do a dressing change and put it back up. It would also make it easy for the dermatologist to access the wounds the following day. Santal was the patient and his wife were instructed on this wound care. They are managing the wound care on their own. He does not have visiting nurses. They can manage it fine, is what they report. And Santal was ordered through the patient's pharmacy. It is a prescription medication, even though it's a prescription topical medication. The patient was also instructed to elevate his legs for at least 30 minutes, 3 times a day, which isn't always possible, but we're realistic with that. If you can, do it. It helps decrease drainage. Instructed he would likely have an edematous appearance of his legs if he did not have the wounds, as the fluid would result in edema. I always explain to people with venous insufficiency that they would have more edematous legs if they didn't have these wounds. I mean, when wounds are huge, like this big, all of the fluid from the leg, which would otherwise be edema if the leg was intact, comes pouring out right through the wound. And I find I explain that a lot to a lot of patients with venous insufficiency, because they just don't, well, how do I have insufficiency if I don't have any edema? You do, it's on your dressing. And follow up in 1 week. Patients are provided not only with verbal instructions, but written as well. So the coding for this appointment, the first ICD-10 code was for a non-pressure chronic ulcer of unspecified part of the right leg, and the second one was for the left leg. My next code is for diabetes mellitus type 2 with diabetic polyneuropathy, which this patient does have. I probably should have put in one for nephropathy as well. If this was primary care, I probably would have. Chronic venous hypertension with ulcers of bilateral lower extremities is the last one. There was a procedural code from the debridement. The code is 11402 of tissue down to the subcutaneous layer. And the CPT code for the appointment was 99214. This was involved. It was a lot of discussing planning and what's been going on with the patient and what direction to go in here with his wound care. So I think 99214 was definitely inappropriate for this appointment. All right, so now, how does this case relate to hematology and immunology? Well, the patient went to the dermatologist at Yale the next day, and the dermatologist diagnosed the lesions as a result of a rare allergic reaction to Coumadin or warfarin. The dermatologist didn't not stop the warfarin on his own. He was in discussing with cardiology what the plan was going to be. but he was pretty sure with the previous biopsy and what the legs were looking like and the description of how the wound started, that it was a warfarin induced skin necrosis. However, before those changes could happen between medication changes between dermacardiology, the patient ended up back in the hospital 2 days after the dermatologist appointment with cellulitis around the right lower extremity wound. Conveniently enough, I got to see the patient on the inpatient side too. So I do happen to know that the patient's Coumadin was discontinued. The patient was started on Eliquis. He had previously tried to take Eliquis, but the problem was the prescription was upwards of almost $600 for 3 months worth. And he just couldn't afford it. I mean, they're on a fixed income. They're retired, 70 something years old. He was switched to Eliquis. His cardiologist said he would work with him. He'll give him samples. He'll help him they have like the discount programs through the pharmaceutical companies. And he said he would work with them to make sure he gets it because he didn't want to put him back on the Coumadin. Warfarin-induced skin necrosis is a rare complication in the incidence. I mean, it's tiny. It's not even 0.1%. It's 1.1 or less. It is thought that the sensitivity to warfarin leads to a transient hypercoagulable state that leads to a vascular occlusion and skin eruption. The actual full pathogenesis remains unclear. There has been an association found with decreased vitamin K dependent clotting factors, such as protein C deficiency, deficiency of protein S, factor V Leiden, and antithrombin 3. I'm again sorry that my pictures are covering the slide. So the picture on the left is what this patient described his wound as looking like when it first started. The picture on the right, I know it's an abdomen, but that's the closest thing that I could find to what I was seeing on his leg. So that is what I was seeing on his leg in the wound center and then also in the acute care setting. The development of microthrombi impedes blood flow to the arterioles and capillaries, leading to skin ischemia and necrosis. These patients may develop photosensitivity, macular papular vesicular urticarial eruptions, purple toe syndrome, skin tissue necrosis, and vasculitis. If allowed to progress, skin changes will usually blister or develop an area of eschar necrosis. Once the necrosis is debrided through sharp or autolytic debridement, a full thickness wound is revealed. Full thickness just means it goes beyond the skin layer and into the subcutaneous layer. A partial thickness wound would be just into the skin. So it is more common in obese women over 40. This guy, he's just got bad luck. Affected areas of the body, such as breasts, buttocks, abdomen, thighs, and calves. It's usually areas that there's a high adipose concentration. And as we know, adipose is poorly perfused. So it is thought that that is why those are the areas that are most easily affected by this rare disorder. In most cases, this reaction occurs early on in the initiation of warfarin therapy. However, there is occasionally a delayed response. One article I read said the delayed response can be up to 3 years after the initiation. Usually the patient's INR is elevated when this happens, but again, that's not always the case. That's really weird. So the treatment, especially for this patient in the long run, supportive wound care, of course, his discontinuation of warfarin, initiating anticoagulation therapy with a factor XA inhibitor, such as Eliquis, or low molecular weight heparins, such as Lovenox. I did find an interesting article. It was, of course, called Warfarin-Induced Skin Necrosis, a Rare Complication. So large starting doses of warfarin deplete protein C and protein S, and those are definitely thought to be part of the problem when the necrosis occurs, when this reaction occurs. Success has been obtained in restarting warfarin at a low dose after receiving vitamin K and fresh frozen plasma to replenish protein C and protein S. There is little evidence that restarting warfarin causes further decline in the skin necrosis. There's really no evidence to say that continuing it would cause the wounds to not heal as well. Unfortunately, there is very little evidence to this. That article of interest I cited on this page, it is, I'm so sorry. Oh, it's this one right here. And Saffold, warfarin-induced skin necrosis, a rare condition. It's from Ghana Medical Journal in 2021. All right, I hope you guys enjoyed the presentation. I hope I didn't babble too much, and I hope this is information that will one day cause a good catch on a patient if it has to happen, right? All right. Enjoy your week, guys. Thank you. Bye.